Hello, so as part of this course, an introduction to disease modelling, I'm going to be taking you through an introduction to random number generation, what a parameter is, what calibration is, and how we might account for uncertainty. So our learning objectives here are to have a basic understanding of what we mean by a distribution, to understand how we generate values at random from a given distribution, to understand what a parameter is in the context of modelling, to understand what we mean by model calibration, to understand what we mean by sensitivity analysis, and to appreciate how we can take into account uncertainty in parameter values to ensure this is reflected in results for our health policy comparison. So I'm going to be talking about these things in the context of individual-based models. Now, an individual-based model is designed to simulate the experiences of people in a population over time. Each time the model is run, it generates a simulated data set of variable values for a cohort of individuals representing the population of interest. So, for example, you can see here the status of a population at a certain time. We have one row for each person in the population, and then we have this variable 1, VAR1, variable 2, variable 3, and whether they're alive or dead at that point in time. And then our model is about how we update the values of those variables from one time step to the next. So we see here the status of the population 3 months later. So here we're using a 3-month time step, and we update the values of the variables for each individual in the population. So if you look at this simple model of cardiovascular disease, and the population, the status of the population at one point in time, you see for each individual, we have a systolic blood pressure value, a total cholesterol value, we have whether they're a smoker or not, and whether they're alive or dead. And then with our model, we will define how to update values, in this case again 3 months later, for each of these variables for each individual. And so you see the values for some individuals have changed from one 3-month period to the next. And an individual-based model is really all about how we define those rules for updating values of each variable for each individual in each time step. So first, random number generation. So as you will see in the online Colab practicals using Python to generate your own individual-based model, generation of a random number drawn from a specified distribution is a key part of building individual-based models. So for example, this distribution called a uniform distribution, which is, there's a figure shows this here. So you have values between 0 and 1. So this is a uniform 0-1 distribution, showing that we're considering values between 0 and 1. And then the horizontal line there shows that the probability of each value being selected on our y-axis is the same. So that's what a uniform distribution is. There's an equal probability of each number being selected. So then a beta distribution is a continuous probability distribution defined also on the interval 0 to 1. And it's characterized by what we call shape parameters, 2 shape parameters, which determine the shape of the distribution. And I've given you an example here where we've chosen the values 4 and 2. You don't need to worry too much about this, but I'm showing you this so that if you come across it in papers that you're reading, you get the idea of what the authors are doing. And so this distribution, you can see the relative probability of each value being selected. So in this case, if you choose a beta distribution with 2 parameters, then around about 0.6, 0.7 is the highest probability of that value being chosen when you sample. But you can see that even values as low as 0.2, there is a small chance that such a value could be selected when you take a random sample. And then there's the gamma distribution. So this is a continuous probability distribution that's defined for non-negative values. So it can be values above 1 as well. And it's also defined by 2 parameters. And in this case, I'm just showing you what it looks like, the relative probability of each value being selected with the values 7, 4. So you can see here, for example, that the value most likely to be selected is up around between 20 and 30, but values as high as 60, there's a small chance that when you take a random sample that you'll get a value of 60. Then we have the normal distribution, which you're already familiar with, also known as the Gaussian distribution, which is one of the most widely used probability distributions. So again, it's a continuous probability distribution characterized by this bell-shaped curve, and it can take negative and positive values. And you can see here the relative probability of each value being selected for a normal 0-1 distribution. So 0 is the most likely value to be selected from that distribution, but values as low as minus 2.5 around there and plus 2.5 also, for each of those there's a small probability that when you take a random sample from this distribution that one of those values will come up. But we can also sample from discrete values rather than a continuous range, and we actually do this quite commonly in the modeling that we do. So here we're considering different values for a parameter. We're not sure whether it should be 5, 5.5, 6 or 6.5. We think it's a bit more likely that it's 5.5 or 6, and so there's a higher probability of those being selected when we take a random sample, 0.3 each, than the values of 5 and 6.5 at 0.2 each. So let's think about how we might go about selecting values at random from distributions to generate variability between individuals in our model. So for example, using the uniform distribution, let's say we're doing a simulation in which our individuals are all adults. And we want to decide for each individual at the start of the simulation whether they have attained a secondary school education. Now, we know from data that 60% of the population have attained secondary school education. So what we might do is use our computer program that we're using for our individual-based model to generate a random number, let's say U, from the uniform 0-1 distribution. Then if that number comes up for this given individual as being less than 0.6, then we'd say that person has attained secondary school education, and we would have a variable in our model indicating whether the person has secondary school education, and that would be true for that person. If, on the other hand, the value of U came up as being above 0.6, then that variable indicating whether they have a secondary school education would indicate that that is false. Now, another example might be, let's say we have a model of HIV infection, and one of the variables we want to include is the CD4 count at the time of infection and beyond. We might then decide, in order to allocate a CD4 count for each person when they're infected with HIV, we might decide to sample, for example, from a normal distribution with mean 400 and standard deviation 100. And this is the kind of thing we've done because this seems to reflect the variable levels of CD4 count in people just infected with HIV. So let's just now have an introduction to what parameter is in this context. So let's talk about what a parameter is in modeling. Let's imagine that our policy question is around whether to introduce a new intervention to reduce risk of cardiovascular disease events, CVD events. We might start by modelling individuals followed over time with a certain risk of them developing a CVD event. We might specify the incidence rate of CVD events and then take into account that this differs by age and sex. These age-sex specific rates of developing CVD are examples of model parameters. So let's say the rate of developing a CVD event in a male aged 40 is 0.003 per year, based on a literature review. This rate is an example of a parameter, and 0.003 is the value we are assigning for the parameter. Now, we might want to specify that a woman of the same age has a lower rate of CVD events. From a review of the literature, we might decide that the rate for women relative to men, the rate ratio, is 0.2. This rate ratio is another example of a parameter, and 0.2 is then the parameter value. So we have the rates of CVD in men is 0.003, and the rate of CVD in women is 0.003 times this rate ratio of 0.2. Now, evidence from a randomized trial may suggest that an intervention reduces the rate of cardiovascular disease. The rate ratio for those given the intervention compared with those not given the intervention, which is below 1 since we know the intervention is beneficial, is another example of a parameter. Let's assume the intervention reduces the rate of CVD by 50% for those who have had the intervention. So the rate of CVD in men given the intervention is now 0.003 times 0.5. And the rate of CVD in women giving the intervention is 0.003 times 0.2 because the rate is lower in women, and then times 0.5 because the intervention has been received. So, for example, we may be modelling changes in fasting blood glucose over time in individuals. Let's say we have a 1-year time step in our model. We might have decided that current body mass index, BMI, is a determinant of the change in blood glucose level. As a result of reviewing literature from cohort studies, we might decide that those with BMI in the range 30 to 39 have a 0.3 probability of a rise in blood glucose of 0.5 millimoles per litre in the following year, whilst those with BMI greater than 40 have a 0.75 probability. These probabilities of blood glucose increases are further examples of parameters, with the parameter values being 0.3 and 0.75. Now, model papers are usually expected to have a table somewhere describing each parameter and explaining the choice of the value or the choice of values that were being used. So, for example, this is just an excerpt from a modelling paper of our own, where you can see amongst a very long list, you can see names of some parameters in the first column, a description of what they represent, and then the values. And you can see in this case we have a discrete distribution sampling from different values, and then the motivation and, if applicable, references which support the choice of values. So coming on now to calibration. Now, sometimes in modelling, we will have a parameter, but we will not choose a single value for the parameter because we're unsure of what that value should be. Instead, we consider a range of possible values for the parameter, and for each value, we run the model and we see what the outputs from our model look like compared with real data, perhaps surveillance data or data from a cohort study. Then we might choose the values for the parameter that leads to the model outputs being most closely aligned with the real data. This process is called calibration. So calibration is the process of trying to ensure that the model reflects reality, at least as far as a model can be expected to do. So parameters, values of parameters that we're going to use to run our model can be determined by hand or by using more objective methods. Ideally, outputs should be within an acceptable range of the data that is known about the disease. In a perfect scenario, we would like to calibrate to all known observed data for any given setting. So, for example, this graph is showing the prevalence of HIV over time in South Africa. And the aim of the calibration is to minimize the discrepancy between the observed data in orange and yellow, which itself has a degree of uncertainty shown with the confidence intervals, the discrepancy between that and the model outputs, which is the blue line. And you can see in this example an extremely close fit of the model to the data up to the final point in 2012. Now, since individual-based models simulate changes in variable values for individuals over time, it is possible to compare model outputs with any source of data by mimicking the way the study collected data and analysing the model outputs in that way. For example, a cross-sectional study can be mimicked in the simulated outputs and results compared with the actual study. And similarly, for cohort studies, you can actually reproduce longitudinal analyses that were done in a cohort study. Now, if a model is well calibrated, it improves confidence in model results. Having a model that is well calibrated to extensive and accurate observed data relating to a high proportion of the model variables provides confidence that the model has a good chance of reflecting reality and providing meaningful predictions. Now, often we're unsure of the values for parameters, and so we can choose a random distribution for the parameter to reflect this uncertainty for each parameter that we wish to include in our model. In an HIV model, for example, we may be unsure of what is the absolute probability of entry into sex work for a woman of a given age and the effect of age on this probability. We might have data from a sample of sex workers on the age distribution, and we may have a separate estimate of the total number of sex workers in the country. So we can then specify distributions of values for these two parameters. Then each time we run the model, we compare model outputs, what comes out of the model, with the actual data. Values of the parameters which result in outputs within our confidence intervals for the data, we would want to use when using our model to study the effect of interventions. So as you've seen, parameters, along with the variables, essentially serve as input values to a model that determine what model outputs will look like. In the context of a model, the parameter space refers to the range or set of possible values, permutations of values that all of the parameters in the model can take. Now, we would ideally like to know what the model outputs look like and how they compare with observed data for every combination of possible parameter values. While this is usually infeasible, we tend to run the model multiple thousands of times each time, sampling each parameter value at random. From this, we get a sense of when the answer to the question we are studying, the policy question, and the uncertainty around it, is no longer changing meaningfully with increased numbers of runs. Approaches to systematically select sets of parameter values include something called Latin hypercube sampling. Okay, let's now come on to accounting for uncertainty. So it's important to consider uncertainty. And there are three levels of uncertainty. So there's uncertainty due to stochastic effects. So due to the fact that, as described earlier, we're sampling from distributions to update variable values for each individual. This means that the model outputs will differ from one model run to the next, even if we're using the same set of parameter values. And then secondly, there's parameter uncertainty. This is where there's uncertainty due to the fact that we're not sure of the value of a parameter. And then thirdly, there's structural uncertainty. It's where we're not certain that our model includes all the important variables which are relevant for answering the policy question. So let's consider these in turn. So first, uncertainty due to stochastic effects. So this is where model outputs differ from one model run to the next with the same set of parameter values. Now we can deal with this uncertainty by running the model multiple times and taking the mean of each relevant output across model runs. We can run our individual based model with a larger number of individuals simulated. So then parameter uncertainty. So this is where we're not sure of the value of a parameter. So parameter uncertainty can be evaluated using the model by running it multiple times with different parameter values and seeing the effect on model outputs. If we are unsure of model parameter values, we would like this uncertainty to be reflected in the model outputs and predictions in the form of an uncertainty range. So for example, if we assume 5% of our modelled people are lost from HIV care every 3 months, we can sample from a uniform distribution to randomly choose these 5%, as we described earlier. However, if we're unsure of this parameter, the probability of loss from care each 3 months, we may want to sample that initial parameter value from a range of potential values. So instead of 5% for 3 months, we can use a computer program that we're basing our model on to randomly choose from between, say, 3%, 5%, and 10% at the start of the model run. So then each time the model is run, a probability of loss from care of 3%, 5%, or 10% will be randomly chosen, for example, with equal probability. During the model run, this value will be used to define the probability of loss from care per time step, as described above. And then we will look at the outputs, and we can see the effect of the different parameter values on the answer to the policy question. So I showed you this table earlier, which is just an excerpt from the table showing the parameter values we had for a paper that we wrote on our model on the effects of introduction of long-acting pre-exposure prophylaxis using a drug called cabotegravir. And you can see that if you look at the third column, that we have specified the range of parameter values we're considering for each model run, and then the probability of each one being selected for any model run. So this shows an excerpt from the paper that table that I showed you in the previous slide relates to. So this is just showing you an excerpt on the effect of cabotegravir introduction on HIV incidence. And you can see that without its introduction, the projected average incidence over the next 20 years was 0.54. And you can see there's an uncertainty range there reflecting the variability across model runs. And then in the second column, you can see the incidence with the introduction of cabotegravir PrEP, which is 0.38, again with its uncertainty range. And then in the final column, you can see that for each model run, we've worked out the percentage reduction in incidence with introduction of cabotegravir versus not, and then given the 90% range to reflect the uncertainty over the incidence reduction. So that's how the variable parameter values, the inputs that I referred to on the last slide, plays out in terms of being able to, for us to be able to produce an uncertainty range for our model outputs. Now, one other common approach when there's uncertainty over a parameter value is something called sensitivity analysis. So this is where you do the main comparison of the policy options using one single parameter value, but then you conduct the same policy comparison analysis except using a different parameter value for one of the parameters. And then you see how much the policy comparison looks different with the change in that parameter value. So this is seeing how much the policy comparison result is sensitive to the choice of that parameter value. So that's why it's called a sensitivity analysis. Now on structural uncertainty. So when building our model, we generally make some key decisions about the structure, i.e. how we want to model certain effects, what variables we want to include. For example, for a model of HIV, we might decide whether we would like to model individual antiretroviral drugs with their own specific susceptibility to drug resistance. These kind of decisions might partially depend on what kinds of policy questions we see our model as being used to address. Now, as we said, parameter uncertainty can be evaluated using the model by running it multiple times with different parameter values and seeing the effect on model outputs. Structural uncertainty, on the other hand, is where we wonder whether the answer to our question would be different had our model been built with a fundamentally different structure. And now it's generally not possible to quantify this uncertainty, which shows how important it is to think carefully about the structure of the model and the variables which need to be included in order to have the best chance of answering the policy question. So I'm going to move on to show you an example based on some work that we've done, which is modelling to understand the HIV epidemic in men who have sex with men in the UK. And it's based around this publication in Lancet HIV on the effect of combination prevention strategies on HIV incidence among gay and bisexual men who have sex with men in the UK. Now, for this work, we used an individual-based model called the HIV synthesis model. Now, each model run generates a simulated population of men with variables updated every 3 months. So the time step is 3 months. And the variables include age, condomless sex partners, HIV testing, use of oral PrEP, risk of HIV acquisition depends on the viral load, the HIV viral load in the partners of the person. And then in HIV positive people, we model the viral load, the CD4 count, the use of specific antiretroviral drugs and specific drug resistance mutations. Risk of resistance is determined by the current adherence to the drug regimen and the activity level of the regimen. Risk of AIDS and death depends on the current CD4 count, current viral load, age, and ART status. Now, there was a range of different observed data items available. So here you can see the range of data items available, most of them for over multiple years. So you can see there was a large number of data items available for the epidemic in MSM in the UK, and most of these data are collected from the UK HSA. Now, each time the model is run, there are outputs which can be compared with the observed data to inform model parameters. And as we know now, this is called calibration. Now, calibration here focused on 26 model parameters relating to condomless sex, HIV testing, PrEP use, effective antiretroviral treatment, etc. So distributions of plausible values for each parameter were determined, with the breadth of the distribution reflecting the degree of perceived uncertainty. The model was then run over 300,000 times, each time using a set of parameter values obtained by random sampling from each of the distributions. Then the model outputs were compared with all the different data items, and a score was derived that reflected the overall distance of the model outputs from the data. So what do I mean by this? So this is an example of the cumulative number of HIV diagnoses over time. The black dots are the data, and the black line is the output from one single model run. And you can see, as illustrated on the graph, how we can sum up the distances of the model output from the observed data. And then we can do this for each calibration data point for each type of calibration data, still for this same single run. So this now is for the number of people on PrEP. Now, when we're doing this and calculating the distances of each data point, we might want to apply some weighting so that more importance is attached to being close to certain data points than others. So when we did this and ran the model 300,000 times, we found 300 of those model runs produced outputs that were close enough to the range of data that we felt was acceptable. So this shows, for example, the cumulative number of HIV diagnoses. The red dots are the data on the left, and the red line is the median over these 300 runs that we considered the data outputs to the model outputs to be close to the data. And then the shaded area shows the 90% range over those 300 model runs. And on the right, you can see the same, but for the number of HIV diagnoses per year. And then a couple of other examples for the data fit. The number of people seen for care for HIV on the left, and then the proportion on antiretroviral treatment of those seen for care on the right. And lastly, the proportion with viral load suppression amongst those on ART on the left, and the number on PrEP on the right. So I'm hoping that now you feel like you have a basic understanding of what we mean by distribution, that you understand how we generate values at random from a given distribution, that you understand what a parameter is in the context of modeling, that you understand what we mean by model calibration, that you understand what we mean by sensitivity analysis, and finally, that you hopefully now appreciate how we can take into account uncertainty in parameter values to ensure this is reflected in results for our health policy comparison.